There it is. Test. So you should be all set.
Okay, let's get started. How's everybody doing? Good. So I'm Dr. Moreno. I'm going to do a little bit of an introduction and stuff, I think in one slide. So welcome to CDM4, the Psych module. I've broken up this lecture into two different parts. We're going to do a brief introduction to psychiatry, and then we'll go into insomnia. Oh, so for Turning Point, this is the session ID. If you guys can do this, we're going to have a lot of questions throughout the lecture. Everybody got it? Okay. Okay, so last year I didn't really introduce the class to myself and give my background, and I thought that since I don't actually meet you guys, or at least most of you guys, until you're almost on Appies, I thought it would be worthwhile to give you a little bit of background on myself. So I grew up in the Midwest, out in Michigan, and I went to school at the University of Michigan. And then I really thought when I was in pharmacy school that I wanted to do industry. And so I went and did an industry fellowship, and that was out here in Massachusetts. It was with Mass College of Pharmacy, but I spent 90% of my time at Cubist Pharmaceuticals, which marketed daptomycin, but is now Merck. So about halfway through my fellowship, which was a 2-year fellowship, I started thinking that I was really missing out on patient care. I loved patient care in pharmacy school and really wanted to get back into that. So I decided to do a residency because I thought that was kind of the best way to get back into patient care. So I went back to the Midwest and did my PGY1 residency in ambulatory care pharmacy at the VA hospital in Ann Arbor. And that was really wonderful, and I loved it. I figured, I felt like I finally kind of realized my calling, that yes, I love patient care. But then I got to do a psych rotation, realized I loved psych. I had already been really interested in it in pharmacy school, about this time that you guys are doing now, just getting into the psych lectures. But so I did a psychiatry rotation, fell in love with it, decided I needed to do a PGY2, so I did another year of training. And I went to Madison, Wisconsin, to their VA hospital and did a PGY2 in psychiatry there. So that's where I did all my training, and then I, right after that, started at Northeastern as a faculty member. My clinical practice site is at MGH, and I work within their substance use disorders initiative. So the entire MGH hospital system did this big community needs assessment, and they asked all of their health centers, what's the thing that you need the most? What do you need the most help with right now? And the community health centers all said, we don't know how to treat people with addictions. We just keep seeing it. People keep dying, and we don't know what to do with them. So MGH put in a ton of money to starting up this substance use disorders initiative, and I got kind of hired on as part of that as the clinical pharmacist of the substance use disorders initiative. And so I split my time between an inpatient addictions consult team, which was the bulk of my work when I first started at MGH, and now I'm starting to do a lot more stuff in the outpatient setting in their bridge clinic, which is intended for people who are very high risk, at high risk of dying, but also risk of hospitalization. It's kind of the people that a lot of other clinics are refusing to treat. We kind of tell them to come and see us. So any questions about my background or anything like that? Okay. And I want to try to make this as interactive as possible. Last year I was not so good at the interactive stuff on the slide, so I really tried to fix that a little bit this year. So I got some really good feedback last year. Students gave me some really hardcore feedback, and it was a little bit hard to hear. But I changed some things this year, and I think that things are going to be better. I also got some really good advice from some of my faculty mentors here. And one of the big things that Dr. Gagno suggested is that not only do I tell you guys the feedback that I got last year, but also kind of doing more of an intro and really get you guys kind of into the headspace that you need to be in for psych. Because it's different. It really is different. It's not, we can't measure things, really. It's not oh, you start a beta blocker and you see the heart rate go down. And you start hydrochlorothiazide and you see the blood pressure go down. It doesn't work like that. Everything is subjective. It's whether or not the patient tells you that they feel better do we even have any idea whether or not things are working? So the seminars are supposed to be kind of in complement to the lectures. They're not really they're going to be a reiteration of some of the stuff that you learn in lecture, but some of the stuff is going to feel like, wait, we didn't learn that in lecture, and that's okay. Like, you're supposed to learn that in seminar. I've created the seminar materials so that the facilitators themselves are equipped to be able to answer your questions, and you're really supposed to be able to kind of see, like, oh, like this is how things come together when you combine seminars with the lecture materials. For questions, if you have a question in class, of course, raise your hand and ask. Please post to Blackboard. I really, really, really prefer that rather than getting direct email questions, because most of the time, if somebody has a question, there's somebody else or 25 other people who have that same question. So I can at least answer the question on Blackboard so everybody can see the answer. I'm more than happy to meet with you one-on-one. I have a little bit of extra time this semester. I've added some Northeastern time to my schedule while I'm teaching. So we can schedule time to meet one-on-one if you're really struggling, or if you just want to talk or you want to learn about psych more than what I teach you in this lecture. If you have like personal things come up, anything that's going on in your life that's really going to conflict with needing to know things in lecture or in this course, like, please don't hesitate to email. I probably pull in Dr. Carlson as the course coordinator because she's kind of the expert and deals mostly with that stuff, but please don't hesitate. So last year, there was this like big to-do because somebody emailed me and asked me for an answer key on something, and I was like, I don't give answer keys. That's stupid. And everybody was like, oh my God, this lady is crazy, and we don't like her, and we don't want to ask her any more questions ever again. So I want to kind of clear the air. So I have a bunch of stuff. You guys may have seen some of the pre-lecture materials that I've been uploading. I have worksheets made. So last year I did these big like drug charts to kind of help you guys organize like all of the stuff about all the different drugs because there's so many medications. And turned out that didn't work and was like not very helpful. So this year I pulled out a bunch of my slides from my lectures last year and turned them into worksheets. And you'll see when you go through, you can like click on the little text boxes that are a different color from like the rest of the slide theme, and you can type in what it's supposed to be. And so the idea is that the slides themselves will kind of guide you in what you're supposed to fill in there. If you have any questions on those at all, don't hesitate to ask. I think they're going to go well, but if they're not going well, please let me know. And I do have answer keys to those, and I will try to keep guiding you. Or if something's just obviously like, why does she think that we're going to be able to fill in this box? This slide gives us no indication that this is even like doable. I will try to help out there. But just asking for like, give me the 47 slides that you made that have all of the answers on it, I'm not going to do that. And I hope that that's okay with you guys. I've posted suggested readings, and I bring them up in every lecture. I'm probably going to pull all of my quiz and test questions from the slides. It's just too much to kind of like ask you guys to do all of this other stuff. There's so many meds that it ends up being kind of a big burden. If you want to do the reading, though, you really want to learn more about it, DePiro is a really good source, and that's where most of the suggested readings come from. So what's going to be on tests and quizzes? Like I said, lecture slides, the pre-recordings, and then what I forgot, I realize now, is the pre-lecture worksheets are definitely testable. Those are going to be actually like a big portion of the test because that's mostly the medication stuff. And then clinical pearls. So I did clinical pearls last year, and Dr. Carlson looked at them again this year, and she's like, you know that all of this information's on your slides, right? Like, you don't need to add this extra piece of information for them. And I went back through and looked at them, and I realized that's exactly true. So I took away most of the clinical pearls this year, but I still have, like within the depression lecture, I have a small clinical pearls worksheet or document that just kind of highlights some big kind of like overarching things to know about the antidepressants. Any questions about this stuff? Okay. So some of the feedback from last year, and you guys can laugh along because this is like, I have pretty thick skin, so this is okay. So she expects a lot was a big thing. Would like more info comparing and contrasting agents. The next slide's going to tell you that I addressed a lot of these pieces of feedback. But we'll try to do a lot more of that, like figuring out what to do with what situation, which agent to pick. Focus was on diagnosis rather than drugs. So this is, again, where psych is very different. The thing with psych is it doesn't always happen that you have some diagnostician telling you this is the specific diagnosis of this person, and this is the exact and then you just know this is the exact medication that needs to treat that diagnosis. Psych doesn't work that way, and so you have to understand the diagnoses, and so there is heavy emphasis on the diagnoses. So while there is heavy emphasis on the diagnosis, trust me, there's also a lot of stuff to do with the medications. So this was the thing about the don't ask me for answer keys thing. After that, I think people started to think that they didn't want to ask me any questions anymore. I'm really not scary. I'm really not. Some of the people who I've been working with on research projects and stuff have worked with me one-on-one, and I hope that they would vouch for the fact that I'm not that scary. I'm 5'2". There's nothing that I can do that's really that imposing. If I get really intense about something, it's either that I'm really excited, because I get really excited about this stuff, or that I'm really anxious and I'm trying to cover it up with being confident. So please ask me questions if you have questions. The type and amount of information was overwhelming, and I'll address that on the next slide. The clinical pearls helped bring things together, so I'm not going to get rid of them totally, but I've just kind of tried to streamline them a bit. And then two people said the quiz and exam questions were too easy, and I was like, oh my God, everybody else is complaining about the material. So I have that on the next slide. Okay, so what I did this year. So I started the pre-lecture recordings. I hope that's going to help a lot, because it's going to give us a lot more time to do a lot more interaction during class, because I took out a lot of the heavy kind of content material that I said, like I said, is definitely going to be testable, but is just a lot of me kind of talking, and there's not a lot of opportunity for interaction there. So added the pre-lecture recordings, and then streamlined the material to be memorized. So I took out the stuff about know everything about everything, and tried to make it be more obvious about the things that you should know. So especially when thinking about the pre-lecture worksheets, I'm probably not going to take from the stuff that isn't highlighted or isn't something that you're filling out. That being said, you should still be relatively interested in understanding the stuff that's not just something that you need to fill out. But I'm trying to be more mindful of the fact that this is a ton of material, and that you guys have a lot to really absorb in order to feel like you're starting to understand it. And then I added this little introduction in hopes of smoothing things over and making things feel like you guys are getting kind of more enmeshed into where your mind needs to be for psych. How did the pre-lecture recording go? Have most of you listened to it? Okay, that's good. Any questions on it? Did it feel pretty straightforward? Did I talk too fast? Those kind of, okay, good. So, things that are not going to change this year. I have high expectations. That's okay. That means that you're in a good school. If you were in a school that didn't have high expectations for you, then you probably wouldn't get really good jobs after. But instead, you're here, and your faculty members are going to have high expectations of you. I'm going to keep the diagnostic criteria and the emphasis on diagnosis for the reason that I just talked about. So as far as the assessment questions, so quiz and test questions, the thing that kind of stinks is I have 6 lectures, and then I get so for tests I get 3 questions per lecture. So I have to pick from 100 slides for each lecture, 3 questions that I want to test you on. So that's really hard to come up with these really intense questions that are definitely testing the information that I know you know. And so it ends up being okay, I'll randomly pick slide 42 and figure out how to make a question about this. And that's just the way it is. And once you guys get on APPEs, some of the faculty members who have educational APPEs, they'll have you guys write quiz and test questions. And that's when students start to realize oh, this is really intense. This is actually quite hard. So just know that it's just kind of the way it is. And we try to do the best we can with what we have. So, intro to psych. So one of the big things, and actually a little bit of seminar is going to focus on this. There was a capstone project, some of you may be in this room, that did a stigma focus. And that's going to be in seminar next week, which is wonderful. A lot of people don't think that mental illnesses are actually diseases. People think that it's all in their head, or they're making it up, or they're just complaining about something that's not really there. And the fact of the matter is that's all wrong. And science tells us that mental illnesses are brain diseases, and there are things that go wrong in the brain, and they cause symptoms. So in this module, we're going to cover 7 different disease states. Last year I covered 8. I had ADHD in last year. I took it out this year, and some of you may be wondering why, because when we work in pharmacies, like 1 million people a day get Adderall or Ritalin. And my answer to that is ADHD is actually very straightforward. If you have ADHD, first line is a stimulant. There's not really much else to it. There's a couple other meds that you can try, but most people are on stimulants. And I didn't feel like I wanted to spend like 45 minutes of lecture on teaching you guys all about ADHD when you either become an expert in it and really understand the nitty-gritty stuff about ADHD, or you just know that first line are stimulants and then that's it. And I promise you that's pretty much all you need to know, unless you become an expert. Okay, so we'll cover insomnia, that's today. Depression is next week. Anxiety and PTSD are going to be combined in a lecture, that's also next week. And then the final week we'll do first psychotic disorders, then bipolar disorders, and then substance use disorders. So last year, another thing that people said was, it's like she thinks that we're supposed to be experts on this stuff. And I thought that this would be worth showing you that experts know about all these things. They don't just know these 7 disease states. So I'm actually not asking that much of you when I teach you these 7 disease states. And I'm just giving you guys the big highlighted stuff, the stuff that you're going to see when you're in community pharmacy, the stuff you're going to see when you're on internal med rotations and other places, even if you're not a psychiatry specialist. So I thought this chart was really helpful. I spent some time on it. I think the PDF version of the slides, if you guys have it, it has a bunch of weird characters in it, but I uploaded a Word document with this chart in it so you can take it from there. So one of the things that makes psychiatry really complicated and annoying for a lot of people, students, if they're really not interested in it, is the fact that all of the meds overlap. And so you can have certain meds treat like 5 different disease states, and that gets really confusing. So I thought that this chart was kind of helpful to show you which kinds of meds can actually be used in different disease states. And the little frowny faces are because it's really not good to use those medications for those disease states. And so the fact that it's like, so benzos are used in GAD, that's not a good thing. So if you put starting lorazepam and somebody with GAD on a test, I'm going to mark you down. But it's highlighted here because it is used. And so when you go into pharmacy practice or when you guys are on rotations, you're going to see that people do use them for GAD. But what I want you to know is that's not a good thing that they're using it for GAD. And I want you to feel empowered to make an intervention and say, did you know that actually SSRIs are first line? And then I also just added in a couple little things about, like, in bipolar disorder, we'll talk about it when we get to that lecture, about how benzos are specifically used to make people sleep. And then in substance use disorders, it's first line for alcohol withdrawal, and so on and so forth. Any questions on this chart? You may have more questions as we actually get into the material. Okay. So the other thing about stigma, the way we talk matters when we talk about, well, everything, but specifically we're talking about psychiatric disorders. When we use negative words, that just perpetuates stigma. And the other thing is a lot of the negative words that people tend to use when they're talking about people with psychiatric disorders or substance use disorders, those words are like really derogatory. And they bring up kind of a certain affect in other people. So when people hear the word abuse, right, that word kind of brings up a certain response in you. You think of domestic violence. You think of people being beaten. You think of really bad things happening when you hear the word abuse. So when people say substance abuse, that sounds really terrible. When in fact, and it also doesn't really sound very medical, right? So we should be calling them substance use disorders. And that's what the Diagnostic and Statistical Manual, 5th edition, which is kind of the Bible for all psychiatric disorders, has now reframed addictions. They're called substance use disorders. So stigma, not only does it just make people feel like crap if they do have a certain illness and they're hearing these really negative terms, but it also makes them, because they're feeling so badly, they're not going to go and seek treatment. They're not going to go and ask for help. They're not going to tell their best friend because they're afraid. They're afraid of being judged. So what we need to do is really avoid using these kind of derogatory and pejorative terms and start talking more medically about these patients because these are medical illnesses. So instead of saying things like she's schizophrenic or he's manic depressive or she's borderline or he's bipolar, instead, let's stop identifying people by the diseases that they have and start identifying them as human beings who have diseases. So she has schizophrenia, he has bipolar disorder, or he has depression. She has borderline personality disorder. He has bipolar disorder. See the difference? Okay. Okay. So any questions on the intro to psych? Thoughts, reflections? All right. So on to insomnia. Oh yeah, so the suggested reading for insomnia is actually not from DePiro because I thought that it was outdated. So I have this article. Here is the citation, and I believe I have not uploaded that to Blackboard, so I will do that today. My apologies for that. Here are the 6 objectives for the insomnia section, and then the first 3 were actually covered in the pre-lecture recording. So we'll kind of review those a little bit with some pre-lecture questions, and then by the end of this lecture, hopefully you'll be able to recommend non-pharm options to treat insomnia. You'll be able to recall adverse effects, PK, drug-drug interactions, contraindications, and monitoring for sleep medications. And you'll be able to recommend the most appropriate treatment option, whether that be non-pharmacologic or pharmacologic, to treat insomnia based on patient-specific factors. So, pre-lecture questions. So I guess we can do turning point. So everybody get ready. So in what stage of sleep do we see relatively increased sympathetic nervous system and brain activity? Non-REM 1, 2, 4, or REM? So go ahead. Okay, stop there. Perfect. Damn it. Okay. So yes, it's REM sleep is when you see. So during REM sleep, you kind of get this like kind of activation. It's almost like it's a little bit like you're awake, but you're definitely sleeping. And so a lot of the things, if you guys remember that chart from the pre-lecture, where like during during non-REM sleep, a lot of things slow down, and during REM sleep, things kind of like speed back up again, and they look kind of more like what people look like EEG-wise when they're awake. Okay. Which of the following is an accurate statement? Stage 1 sleep is more restorative than stage 4 sleep. REM sleep is more restorative than stage 3 sleep. Stage 2 sleep is more restorative than stage 4 sleep. Or stage 4 sleep is more restorative than stage 2 sleep. Participation is so much better than last year. This is impressive. Okay, I'll stop it. Okay, great. Yes, stage 4 sleep is definitely more restorative than stage 2 sleep. And those slides in the pre-lecture really kind of outline that. Okay, question 3. Which age-related sleep change is relatively common for adolescents? Frequent nighttime awakenings, advanced sleep phase syndrome, delayed sleep phase syndrome, or having less deep sleep? Okay. Yes, delayed sleep phase syndrome. Can somebody explain that to me? Go for it. Exactly. Pretty straightforward. You go to bed later and you wake up later. And it's just what the body wants to do. So question 4. Sam is a relatively healthy 55-year-old male. He doesn't smoke. He exercises regularly. He eats healthy and drinks 1 to 2 glasses of wine with dinner each night. He reports that for the last 2 to 3 weeks, he's had a tough time sleeping throughout the night. He falls asleep just fine around 10 p.m., but wakes around 2 a.m. and continues his sleep pattern until he wakes up for the day at 6 a.m. He's asking you for help because he started staying up much longer each time he wakes and is having more trouble getting back to sleep. So what type of insomnia does Sam have? Is it initial insomnia that's persistent, initial insomnia that's recurrent, middle insomnia that's episodic, or middle insomnia that's recurrent? Okay. Ooh, we have a little bit more of a divide here. So So most of you guys said middle insomnia that's episodic. Why did you say that? Anybody? Go for it. Mm-hmm. Anybody have a different opinion for who said it was recurrent? Recurrent lasts longer, right? How long, or what's the definition for recurrent? Yeah, exactly. So it's like having a significant period of time, at least twice a year, where you're having trouble sleeping. So it is middle insomnia that is episodic. Okay, question 5. Which of the following choices below lists sleep-promoting neurotransmitters? Norepinephrine, histamine, and orexin, GABA, adenosine, and melatonin, serotonin, which is abbreviated as 5-HT, histamine, and acetylcholine, dopamine, norepinephrine, and serotonin. Awesome. Okay. Yep. So GABA, adenosine, and melatonin are all sleep-promoting. The other ones are all wake-promoting, except for histamine. Or, I'm sorry, never mind. Histamine is wake-promoting. Okay. Question 6. Nancy is a pleasant 67-year-old healthy female. She reports to her PCP that she has trouble falling asleep for the past 6 months. She states she likes to try to go to bed, that's a typo, it's supposed to be to bed, around 10 p.m. each night with a goal to wake up at 5 a.m. However, recently she's not been able to get falling asleep until 2 a.m. How would her insomnia disorder be specified? Is it terminal insomnia, episodic insomnia, persistent insomnia, or recurrent insomnia? Okay. Yes, she has persistent insomnia. This has been going on for 6 months. Okay, so now let's get into how do we treat insomnia. So this slide is looks a little bit complicated, but it's pretty easy to follow. So the first thing you want to do when somebody tells you, I'm having trouble sleeping, is say, tell me about that trouble sleeping. Because there's no point in saying, like, oh, go to that aisle and pick up the Benadryl, or go to your doctor and get a prescription for something. Because you don't really know what's going on. You want to understand everything that's going on. And one of the things that I said it in the pre-lecture material is that it's less of a brain disease, insomnia, compared to the other psychiatric disorders. The reason is because usually there are so many contributing factors to insomnia, like other outside factors, like people are stressed out. Maybe they have a different mental illness that's causing them to have trouble sleeping. Maybe they have really terrible sleep hygiene and they're sitting with their phone this far from their face and laying in bed at night, and that's why they feel like they can't fall asleep. So it's really important to really gather a ton of background information when talking about ways to treat insomnia. So the first thing you want to do is get their full sleep history. So you ask, how many hours of sleep are you getting? How many times do you wake up during the night? What time do you go? And like, instead of asking, so a lot of times people will say, how many hours of sleep do you get? And people kind of estimate. And most of the time people actually underestimate what they're getting. Or overestimate, depending. But so what you really want to do is make sure you ask the times, like what time do you fall asleep and what time do you wake up. I had a patient at the VA once who had like messed up his understanding of AM and PM, and we found out that he was actually sleeping like 14 hours a day because he told like, because we kept saying like, how much are you sleeping? And he kept being like, I'm not getting enough sleep. I'm so tired all throughout the day, and I'm only getting like 5 hours. And I can't remember how the math worked out here. When he actually told us like what time he fell asleep and what time he woke up, we realized he was sleeping for like 14 hours a day. He had like terrible depression, and we really needed to treat his depression. So it's really important to get like really as objective evidence as you possibly can with these patients. So full sleep history, everything you need to know, or everything you could possibly know about their sleep, that's all the information that you want. Alcohol is a big thing to know about because alcohol can negatively affect sleep, and we'll talk about that. Ask about chronic medical conditions. Are there other things that are causing this? people have pain, that causes them to stay up at night. If they have breathing issues, there's a whole assortment of breathing issues that can cause people sleep difficulty. But even imagine like with congestive heart failure, like if they lay down all the way, they feel like they can't breathe very well, and then they have to like put a bunch of pillows behind them, or some people sleep sitting up in chairs because they have heart failure, and that's the only way they can breathe throughout the night. Ask about other medications that they're taking. So is there anything that they're taking that could be causing them insomnia, could be stimulating them in some way? Ask about family history of insomnia, because it can run in families, mostly with the primary insomnia. Of course, ask about mental illnesses, if they're really depressed, or if they're really anxious, or if they're manic. There's a whole bunch of things that could contribute to people having really a difficult time sleeping. And then, if all of that stuff seems like, nope, there's nothing wrong with any of these things, everything is just fine, then you want to ask them things about potentially sleep apnea. So, are you having daytime sleepiness? Are you really tired all throughout the day? You feel like, and are you falling asleep? Like, even if you just sit up in a chair for 2 minutes and you just fall asleep, does that happen? Has anybody ever told you that you snore? And then, if you're especially overweight, that tends to be more common with obstructive sleep apnea. There are 2 different types of sleep apnea. One is central, and that's when the brain is just like basically turning off the drive for the lungs to inhale. But the other one is obstructive, and so if there's a lot of tissue around the neck, that can actually close the breathing passages while people are sleeping. So then you want to also ask about, like, well, how has this gone for you? How long have you been dealing with this stuff? So evaluate their course of insomnia, or sorry, the cause. So we need to treat anything else that could be causing insomnia. If it is a psychiatric illness, if it is a medical illness, of course we have to be treating those things. Sometimes things are medication or substance-induced. So if somebody has been on a cocaine binge for a week, then they haven't slept. That's not mania, and that's also not insomnia. That's a cocaine binge. Or if they are, of course, all of the other substances, like I said, that can really kind of wake people up and make them feel like it's difficult for them to fall asleep, we'll want to make sure we're ruling those out. The other thing that medications and substances can do is actually the withdrawal of those substances can cause people to feel insomnia. So if people have been on opioids for a long time, or have been drinking alcohol, or been on benzos, for anything that slows them down, and then we take that off for some reason or another, whether it's part of an addiction treatment program or whether the patient just decided to stop, that can also cause insomnia. And we can treat that in certain ways to help them kind of get through that period of time. If a co-occurring condition is identified and treated, most patients recover really quickly. That's the cool thing. Like even like with sleep apnea, which is like a medical illness and it's really complicated and annoying, all you have to do is like put on like a CPAP machine and then people sleep like babies. So, and it's quick. It's like instant fix. When people fix their sleep hygiene, which we'll talk about what sleep hygiene looks like, their sleep also gets better really quickly. It's pretty amazing how quick sleep can resolve insomnia can resolve once we actually address all of the issues that are contributing to it. If people have, like the woman with the 6 months of having difficulty sleeping, people are having persistent and chronic insomnia, CBT, which is cognitive behavioral therapy, which I think I have a video on that in the depression lecture Blackboard folder, can address and treat really severe insomnia. And the theory behind CBT is that you're actually changing the way that people think about certain things, and you're changing their behaviors. And when you change the way that they think and you change the way that they behave, then things start to get better. And then unfortunately, for a pretty small percentage of people, there is treatment-resistant insomnia, and that's what we see when it's more hereditary and runs in families, and it's very difficult to manage and usually just requires a ton of medications. So non-pharm options are first choice for almost everybody. They're considered standard of care. Parts of CBT, or that cognitive behavioral therapy for insomnia, can include all of these things that I have listed, and we can actually take from some of those things when we're making recommendations for people for what they can do to address their insomnia. So behavioral interventions are things like, and I'll go through each of these in individual slides, stimulus control. So that's like outside stimulus that's causing people to feel activated. Sleep restriction, relaxation training. You can think about other types of cognitive therapies, but what the people who are really into the whole CBT for insomnia, what they always say is, like, while the cognition and what people think about how they sleep is very important, the behavioral stuff is absolutely paramount. And so it's so much of the sleep hygiene that people really need to be addressing, and then maybe a little bit of how they think about falling asleep. Okay, so I must have taken those out. So I will go through them then. Stimulus control is basic, like I said. So that's like turning the TV off, not having your phone this far away from your face, really reducing, they call it, I don't know if a lot of you guys have maybe heard this yet, but like blue light is a big culprit in insomnia. And so now iPhones actually have the setting where you can have like the nighttime setting, and it makes your screen look yellower. I use that all the time. Anything that like causes our body to feel activated. The reason the blue light is such a problem is that it actually turns off our melatonin and tells our body like to not release melatonin. It thinks it's daytime outside. So that just automatically causes us to be awake. And we want melatonin when we want to go to sleep. Sleep restriction is interesting. It's telling people to sleep less for a short period of time. So maybe they want to sleep like 8 hours a night, but right now they're only sleeping like 5 hours a night. Well, you actually have them sleep like 4 hours a night, and then they wake up at a certain time, and they have to stay awake like the whole day. So ideally, they're not like operating heavy machinery or driving long distances during this experiment. But then the idea is that hopefully you've made them tired enough by the next time they go to bed that then they'll sleep for a longer period of time. But you do sleep restriction over maybe like a couple weeks, and then you slowly start increasing the amount of time that you let them stay asleep. And after a period of time, they end up being able to sleep totally normally. And then relaxation training is a lot of the like meditation, clearing the mind, slowing the mind down, getting rid of unhelpful thoughts, and getting kind of zen. Okay, so pharmacologic options. Oh, here, I messed this up. Sorry, guys. I just talked through all of this stuff. I should have taken out that pharmacologic option slide. I will update the slide deck when we, after this lecture, and I'll just remove that slide just because it's in the wrong spot. So I just talked about stimulus control. I'm not going to go through it again. And sleep restriction therapy. Oh, I have noted here, avoid sleep restriction therapy in certain kinds of patients because they can make their other illnesses significantly worse. So you don't want to do it in patients who have epilepsy. It can cause them to have a seizure. You don't want to do it in people with bipolar disorder because actually sleep restriction can switch them into mania, which is a medical emergency. And we'll talk about that when we get to the bipolar lecture. Or people with sleepwalking disorder. And then relaxation we just talked about. Any questions, because I went through those kind of quickly? Okay. So cognitive therapy, like I said, it's about changing the way you think. So what happens when people get in a really bad cycle of insomnia is that they end up being really anxious and fearful of not being able to fall asleep. And then it's kind of one of those things like, well, if I fell asleep now, I'd get 6 hours of sleep. If I fell asleep now, I get 5.5 hours of sleep. And they start doing all of these things about really I need to fall asleep. I have a big presentation tomorrow, and if I'm tired during that, it's going to be so hard for me to do this presentation. And so cognitive therapy is really intended to reduce the anxiety about falling asleep. It also is intended to dispel misconceptions about sleep and insomnia. And so there's some what we call psychoeducation that we do with patients when we're doing sort of cognitive training with for insomnia, because a lot of times people think that there's like a lot of other things wrong when they have insomnia, a lot of medical things wrong. They'll also be, again, it's all about this like anxiety and fear of not being able to fall asleep. And so kind of telling people like it's okay if you have trouble sleeping for a little bit of time, and you'll get back to being able to sleep again soon. Okay, sleep hygiene. So like I said, there's a ton of stuff. I don't need to go through all of these because it's really just a big long list of things people should or shouldn't be doing when they're trying to go to bed. I just talked about how phones and computers are pretty bad because of that blue light, and they've actually done some science and shown that it's actually worse than TV. And the theory behind that is because if we're holding an iPad or we're holding a phone, it's like close to our face, and so that bright light is kind of shining right on us. Whereas like a TV is usually at least some further, hopefully 6 to maybe 15 feet away from us. And so when it's that far, it's thought to be like kind of like less intrusive into that whole melatonin system. There's a whole bunch of things, and a lot of things that I remember, like when I was in college, I think I did all of these things all of the time, and no wonder I had trouble sleeping when I was in college. But when you read through them, you're kind of like, ooh, I should change some of that stuff. So you'd be surprised once you start kind of like cleaning out, like going through this whole like laundry list of things that you can fix, how much better your sleep actually gets. So question 7. If a 43-year-old female came into your outpatient pharmacy to ask for help choosing a sleep aid, what would you recommend? Would you first refer her to her PCP to start a prescription agent? Would you first consider behavioral strategies for sleep? Would you first refer to a therapist for CBT for insomnia? Or would you first try an OTC sleep aid like diphenhydramine? Great. Yeah, behavioral strategies. We don't need to do, like I said, so the first thing, even before we made the recommendation, what else would you do, even before that? Ask about their sleep, right? We need to collect all that information to understand what's really going on. Because, sure, certainly if something like really terrible is happening, instead of us just being like, oh, you need to do these like, you know, Zen things to get you all relaxed and stuff to go to bed, and like actually the lady needs to go to the emergency department for something. Like we should be collecting some of that information. But yes, considering behavioral strategies for sleep is the way to go here. Okay, so now on to pharmacologic treatment. We'll start with benzos. So we'll spend a bit of time on benzos, kind of talking about pluses and mostly minuses of them. Of course, if anything gets confusing, please ask questions. So there are 5 benzodiazepines that have an FDA-approved indication for insomnia. They are listed in the chart. That being said, I very rarely see astaxanthin, clozapam, or flurazepam. I don't even know if I'm pronouncing those correctly because I never see them. So I've seen triazolam and I've seen temazepam a few times. The ones that I have listed below, so lorazepam, which is Ativan, diazepam, which is Valium, clonazepam, which is Klonopin, and alprazolam, which is Xanax. I see those 4 all the time. So a lot of times PCPs, psychiatrists, anybody who's prescribing benzos are a lot more comfortable with these 4. And I don't know why that is. Maybe the drug companies marketed them better 30 years ago. So the way they work is that they non-selectively bind GABA A alpha subunits. So, and I have a picture to kind of show you what the subunits look like. But we have GABA receptors in our brain, and they kind of like slow everything down. And benzos bind to parts of those receptors, and they help slow everything down more. So what that does to sleep is it decreases sleep latency. The definition of sleep latency is the time it takes to fall asleep. So reduces the time it takes to fall asleep. It increases stage 2 sleep, which if we remember is like a little bit deeper than stage 1, but it's like not that restorative. And it decreases the restorative sleep. So it decreases stage 3 and stage 4 sleep, and then it also reduces REM sleep. But they do increase total sleep time. It's just that you're not getting as much quality as you are quantity. So, some warnings. You could see some abnormal thinking, and they call them complex sleep-related behaviors. These are the things like people wake up in the middle of the night and they eat everything in their fridge, or they like wake up and they drive 20 miles and then like all of a sudden don't know where they are and they're like really awake. Those are the complex sleep-related behaviors. All sedative hypnotics carry this risk, so as well as the Z drugs, which we'll talk about in a few minutes. Benzos really shouldn't be used for longer than 7 to 10 days at a time. The FDA has approved longer use, especially for some of the different agents, but that doesn't mean that it's good. It's just because the drug company designed a trial that said that, like, for some reason this is safe. These are the kind of drug trials where I say don't trust the evidence there, only because of my experience with working with patients that are either addicted to benzodiazepines or are what's called pseudo-addicted, in which case, which is that they feel like they need them so badly that they're unwilling to give them up. Don't use benzos for people that have breathing problems. So sleep apnea, COPD, asthma, it's usually not a good idea. You'll see some pulmonologists prescribe benzos, very low dose, for people that have what's called air hunger, so they're breathing too much. And because benzos slow down our respiratory drive, it kind of helps them reduce their anxiety of that air hunger and helps them breathe more fully. But don't worry, I would never test you on that. And it's very rare that people need them for that. So most breathing problems are like a big, pretty much like relative contraindication for benzos. Substance use disorders are another relative contraindication for benzos. Because so once that addiction switch gets flipped in the brain, and we'll talk about this in the last lecture, but once that addiction switch gets flipped, you're kind of basically addicted to anything that's addictive. And so benzos are addictive, and so once you start benzos, it's more difficult to get off. It's difficult for anybody to get off of them, but specifically in somebody with a substance use disorder, they usually will end up getting addicted to the benzos too. Pregnancy is a big no-no because they cause congenital malformations. So tolerance to benzos will develop in about 4 weeks, but you could see it sooner with some of the different agents. For example, triazolam takes only about 2 weeks to start seeing some of that tolerance. And the definition of tolerance is needing more and more to get the same effect. Withdrawal occurs with abrupt cessation. So if you stop a benzo right away, you will see withdrawal symptoms. And withdrawal can be very terrible from benzos in the fact that people can have seizures and die. So we have to be very, very careful with benzos. There are worse benzos that cause worse withdrawal, and that depends on their half-life, which I think I have some slides about. And you just want to be really careful when somebody has made the decision to come off of a benzo. You really want to guide them and help them do that slowly. Patients could experience rebound insomnia upon stopping. So this is why it's kind of like benzos aren't that great, because you started them to help you fall asleep, and then you want to stop them, and now you have insomnia again, and maybe it's even worse than it was before. So this is why I usually say benzos are really terrible. And we will talk a lot more about them in the anxiety lecture. So maybe that's where I have the picture of the GABA receptor. So we'll see that next week. So, which of the following is true regarding the utility of benzodiazepines for insomnia? Benzodiazepines increase restorative sleep, they increase sleep latency, they are associated with tolerance, or they decrease sleep latency. Okay. Yeah, so it's definitely C and D. I hope that I put arrows next to both of those. I haven't looked at these slides in a few weeks. Ah, shoot. Okay, they're definitely associated with tolerance. So the answer is C and D for this one. And they decrease sleep latency, so they decrease the time it takes to fall asleep. Okay, Z drugs. So Z drugs are also known as non-benzodiazepine receptor agonists, or NBRAs. We just call them Z drugs because almost all of them have the letters, they all have the letter Z in them. So they are azopiclone, zaloplan, and zolpidem. So they work by selectively binding the GABA-A alpha-1 subunit. So whereas the benzos will bind, there's like 5 alpha subunits, and so benzos will bind like all of them, but the Z drugs only bind the alpha-1 subunit, and it's thought that the reason that these drugs were developed is that if they selectively bind the alpha-1 subunit, then they're only going to affect sleep, and they're not going to have all of these other terrible effects. When in real life we found that they do have some of the other terrible effects, but maybe they're less severe compared to benzos. But they're very similar to benzos overall. So it's possible that they have less tolerance and maybe less rebound insomnia, again related to that selective binding of the alpha-1 subunit. But at the same time, you should still limit their use. They shouldn't be used for years on end. You want to ideally go for less than 4 weeks to reduce that risk of tolerance and dependence, even though the FDA has approved azopiclone for longer. So fair game for quiz and tests, I'm only including zolpidem IR dosing. So for males, it's 2.5 to 10 milligrams as needed for sleep. For females, it's less. So the maximum dose for females is only 5 milligrams. And that's because they found that if they use Zolpidem IR up to 10 milligrams in females, the females are much more likely to get like all of the negative side effects, especially related to those complex sleep-related behaviors. So the warnings and adverse effects are very similar to benzos because they work so similarly to benzos. You can see withdrawal in some percentage of patients, not very high. And that withdrawal could look like fatigue, nausea, vomiting, flushing, lightheadedness, which is what LH stands for, uncontrolled crying, nervousness, or panic attacks. Azopiclone has an unpleasant taste, and about a third of patients are going to report that to you. And you could see headaches. For drug-drug interactions, basically anything that also slows you down is going to kind of compound with Z drugs, same for benzos. So anything else that's a CNS depressant is just going to add to that. CYP3A4 inhibitors or inducers are going to, so inducers will decrease the effects of azopiclone and Zolpidem, and then inhibitors will increase those effects. For monitoring, you're going to want to ask patients about adverse effects, if they're experiencing any of those things, if they have eaten everything in their fridge, or if there's experiencing sleep improvement, if things are actually getting better. And not only sleep improvement, but also the daytime fatigue. You want to make sure that this, because the whole problem, why insomnia is a big thing, is that people, for the 2/3 of their life that they're spending awake, feel like they're not getting very much out of it. They feel very tired and feel very unproductive. And so what you want to make sure is that people are also getting more out of the time that they're awake and that they're starting to feel better that way. And then also trying to see if people are developing tolerance. If they started at 5 milligrams and they're saying, Doc, I need to go up to 10 milligrams because 5 milligrams just isn't working anymore. That's telling us that there's tolerance. For treatment duration, azopiclone and then Zolpidem ER had big randomized controlled trials that showed that people did not develop tolerance, or that there was no difference in developing tolerance between the treatment arm and the placebo arm after 6 months, so that's why they're approved for that long. That being said, or there's no really restriction on their duration. Like I said, I don't recommend that for anybody, and I would say still keep it to less than a month. So for patient education, for Zolpidem ER and azopiclone, those ones are really focused on helping people stay asleep. So they have long half-lives, and you want to make sure that the person actually has like a good chunk of time to sleep. So if this is somebody who's going to bed at midnight and they need to wake up at 4 a.m. for something, don't tell them to take one of these 2 medications, because they're going to be very, very sleepy. They're probably going to be doing the complex sleep-related behaviors. What happens a lot, I actually have a friend who was taking, I think, Ambien. And she said she was in college, and she was taking it to help her sleep. And then one day, she woke up standing in the laboratory that she worked in, and her boss and everybody was totally normal. They thought that she was being totally normal, and she's like, I just woke up from sleep, and I'm standing here, and I'm talking to you people, and I have no idea what's going on. And she lost 10 hours of her life. She's like, I don't know what happened. It's she completely blacked out. She never took it again after that. And that's the kind of stuff where that means she got up, she got out of bed, she changed her clothes, she walked to the lab, she started working in the lab, and then woke up. So it's pretty intense. And so these are why I'm I don't think I would recommend that for my mom. So I don't know if I would recommend it to anybody. Okay, so that's why I said, so impairment can be present even if people feel like they're awake. And so that's a big thing too. People are driving, you feel like you're fine. I mean, this is the people who have 3 drinks and they're like, oh, I can drive after 3 drinks. They feel fine, but there's still impairment there. That's definitely a significant thing to be concerned about. You want to take these on an empty stomach because food delays absorption. So say you eat a big meal, you eat I don't know, half a pizza at 10 o'clock at night, then you take your Zolpidem, and then you go to bed. Maybe you fall asleep, but your Zolpidem's not going to be active for another several hours, so then you're going to be much more tired and sleepy again that next day. And we talked about the complex sleep-related behaviors. Okay, which of the following is not an adverse effect of benzodiazepines or Z drugs? Night eating, anterograde amnesia, Stevens-Johnson syndrome, or next-day drowsiness? Stevens-Johnson syndrome. Everything else we definitely see. For the record, they tell us not to include these kinds of questions on quizzes and tests, like choose the thing that isn't what I'm asking you. But I like to include them in lecture because I still think that this kind of helps you think through, like, these are the things that I don't expect to see. This is more real life. So I'm going to include them in lecture, questions like this, but you're probably not going to see anything like this on a quiz or a test. Okay. Which of the following medications can be used for over a month at a time? Zolpidem IR, azopiclone, temazepam, or Zaloplam? Okay. Yep, azopiclone. Everything else says to max out at about 4 weeks. Okay, sedating antidepressants. Any questions so far on benzos or Z drugs? Yeah. I would say call the doctor and double check, because that's definitely a significant thing to, because if it's somebody, so the question is if you get a prescription faxed to the pharmacy or whatever, that's, it just says Zolpidem on it, and you don't know if it's IR, ER, or CR, or whatever, it's important to double check, because maybe it's somebody who has trouble staying asleep. And so if they have trouble staying asleep and you give them the IR, they are probably more likely to wake up after like 4 or 5 hours, because the IR only lasts for a shorter period of time. It has a shorter half-life. And so maybe the intent of the person prescribing them that medication is to help them stay asleep longer. And then the vice versa is also really true, right? If they really just need help falling asleep, but they stay asleep just fine, and they don't want the next day drowsiness, or they're afraid of the next day drowsiness, then you want to give them the IR. Make sense? Any other questions? Okay. So a lot of times, because people like me and maybe some other people who work with psychiatric disorders don't like benzos and don't like Z drugs because of the tolerance and because of the complex sleep-related behaviors, we try to find other things that can help people fall asleep that are a bit safer. And the things that most of the people that kind of like work in the like psychiatric pharmacy world recommend are on this slide when they're talking about, especially if you have somebody who is struggling with symptoms of anxiety or symptoms of depression, then trying to kind of cover 2 birds with 1 stone with a sedating antidepressant, it's a good idea. So the ones that are most commonly used are doxepin, which is a tricyclic antidepressant. So it's not commonly used for depression anymore. We'll talk about that when we get into the next week's lectures. But it is used at low doses for insomnia. It is FDA approved for insomnia, whereas the other tricyclic antidepressants are not, even though they all cause sedation. The way that it works is that it has like antihistamine or anticholinergic, they're kind of the same thing, effects at low doses. And so what we see a lot, and so that low dose rather is 3 to 6 milligrams. I want to take it on an empty stomach, again, because food will delay the absorption of it. Where we see, so antihistamine effects and anticholinergic effects kind of should always like bring to your mind a few key things. And they basically are the adverse effects. So you may see some next day somnolence from doxepin, and that's because it is quite sedating, and that's what we see with antihistamine agents. But the other adverse effects that you'll also see are things like blurred vision, dry mouth, constipation, flushing, and all the other kinds of anticholinergic actions that you're used to seeing when you think of agents that have anticholinergic effects. Drug interactions for doxepin, the levels would be increased by CYP2D6 inhibitors. So for trazodone, trazodone is actually not FDA approved for insomnia, but it's used almost all the time for insomnia. It also works through those antihistamine effects. Dosing for sleep, I mean, it doesn't really, there's not really a maximum here, but typically I'll see things as low as 25. I've even seen 12.5 in like really elderly people who really have a lot of difficulty sleeping, up to like 200, but the maximum dose of trazodone, because it is an antidepressant, is like 600 milligrams a day. Once you get above about 300 is when you start seeing actual antidepressant effects. So you wouldn't really expect much improvement in mood or anxiety at these low doses of trazodone. But you do see a lot of the antihistamine and really sedating effects. So with trazodone, and with all antidepressants, there's a black box warning for possibly increased risk of suicidal ideation. That's what SI stands for. The suicidal ideation typically, and this will be in next week's slides, but it's mostly in younger patients, so under the age of 26, I believe. And that's where the studies had shown that increased risk does exist. You can also have an increased QT interval. Because trazodone affects serotonin, and there's serotonin on platelets, you could have possible bleeding, especially if it's combined with antiplatelet agents or anticoagulant agents. You can see orthostatic hypotension with trazodone, GI upset, and then xerostomia, which is that dry mouth. Drug interactions, there aren't really any significant drug interactions that we think of with trazodone, other than maybe if you're combining it with other CNS depressants, you'll again see that like compounded sedating effect. And then it's often used first line for insomnia. So even though it's not FDA approved, we typically go to it very commonly. And then for mirtazapine, it's also not FDA approved for insomnia, but we use it pretty commonly. It also has those antihistamine and anticholinergic effects. You want to do low-dose mirtazapine to try to get after the sleep effect, because once you get, so the interesting thing with mirtazapine, and I have a slide on this next, is that it actually has this like paradoxical opposite sedation effect. So at low doses, you have that predominant antihistamine effect. So you have a lot of sedation, a lot of dry mouth, blurred vision, all those adverse effects that could happen. So that's like 7.5 is very low dose. The maximum dose of mirtazapine is like 45, and I've seen people up to 60 before on it. But as you get above 15, the sedative effects actually reduce, and people start to feel a bit more awake. And so once you get up to 45 milligrams a night or 60 milligrams a night, you're actually not getting any sedative effect at all. So with mirtazapine, like with other antidepressants, there's a black box warning of suicidal ideation. Weight gain is very significant with mirtazapine. So we tend to go for mirtazapine when you have somebody who has a lot of trouble sleeping, who maybe also is either depressed or anxious, and who is very skinny, like that they could stand to gain 15 to 20 pounds, because the weight gain is quite significant with mirtazapine. Because the weight gain, kind of hand in hand, what goes with weight gain is also all of the other kind of metabolic effects that you'd expect. So you can see also increase in lipids. And then also xerostomia as part of the whole anticholinergic effects. Again, no clinically significant drug interactions. And like I said, it's good if a person has concomitant depression or anxiety. And so we'll definitely talk a lot more about antidepressants once we get to the depression lecture. So these ones, basically, like for insomnia, you only need to know the stuff that's on the slides for these. So next question. Stephen is a 60-year-old male reporting many sleepless nights for the past 6 months. He practices good sleep hygiene. He reports some anxiety symptoms. His current BMI is 19. He is on levothyroxine, 50 micrograms daily. So which medication is the most appropriate treatment recommendation for Stephen? Is it mirtazapine, 15 milligrams at night, trazodone, 50 milligrams at night, zolpidem, 5 milligrams at night, or clonazepam, 1 milligram at night? Okay. I thought this was going to happen. Okay, so trazodone's not wrong. It's definitely not wrong, and it would be pretty appropriate, like if you were in a clinical setting. But try to think about what would be the best option for this person. And maybe this felt tricky because I was just talking about mirtazapine, so you guys are like, no, it's not mirtazapine. But I was thinking mirtazapine, and the reason for that is that he's also experiencing anxiety, and trazodone at 50 milligrams is not going to touch that anxiety at all. Whereas mirtazapine, the minimally effective dose of mirtazapine is 15 milligrams a day, and that still has a lot of sedative effect. And so mirtazapine 15 milligrams at night could cause, and his BMI is 19, which while it's normal, it's on the lower end, so like it'd be okay if he gained a few pounds. So it can address, it's not going to be harmful for him to gain a bit of weight. It'll help with his sleep, and it'll help with his anxiety, whereas trazodone's not going to do any of that. It might help with the sleep a little bit. Any questions? Did that help clarify? Okay. So why don't we take a break, because I've been going for over an hour. And why don't you guys come back here at 9:45. Okay. So the next segment of pharmacologic options for insomnia is melatonin receptor agonists. So we have two of them. One of them is actually melatonin, so that makes sense that that would be an agonist for melatonin receptors. And then the other one is Ramelteon, which is also called Rosarum. That's the brand name. So melatonin is an agonist at the melatonin 1, 2, and 3 receptors, whereas Ramelteon is an agonist at just 1 and 2. So Ramelteon is an FDA-approved prescription agent for insomnia, and so because it went through the entire FDA approval process, it has a lot more data on its use and effectiveness and all of that, whereas melatonin, we don't have that. Melatonin is currently sold as an over-the-counter agent, and not only over-the-counter, but also like in the idea of like CAM remedies, so like complementary alternative medicine. So it's thought to be like more natural, but it's not. It's just another pharmaceutical product. So we talked about this a little bit before. So melatonin is this endogenous hormone that we have in our bodies that tells us to go to sleep. So if we give ourselves more of that, then hopefully it would help us go to sleep easier. And what it seems to be true, like it turns out that that's actually pretty true, that if we take something that is an agonist at our melatonin receptors, then that actually helps us go to sleep. So Ramelteon is, or rather both of them, can be really helpful, especially for patients that have like jet lag or some sort of like sleep phase problem. So with jet lag, of course, you can imagine you have like a 6-hour time change, you need to go to bed, you're not tired yet. You can take melatonin or Ramelteon. It'll help you go to sleep, and then hopefully get a full night's sleep and wake up the next day feeling a bit more refreshed and ready to go about your day. Or if people have low endogenous melatonin. Now, I've never seen anybody test for a melatonin level, so I don't know if that's even I don't think that that's a normal part of practice. But you can imagine if somebody like naturally has low melatonin, that it would make sense to supplement that with some sort of endogenous or exogenous agent. So these agents are considered safe for short-term use, but I mean, I've seen people use melatonin for years and it be pretty much completely fine, and they can miss doses several nights a week, and like that's totally fine too. They don't have withdrawal or anything like that. Has anybody in the room, if you feel comfortable sharing, like tried melatonin to help with sleep or anything? And what's your experience been? It did? Yeah, especially with those having to like shift your phase of sleep. Melatonin agonists tend to be really nice for that. Did you say you've also used it? Any experience for you? Oh, sure. And did it help you sleep? Good, good. So, yeah, so a lot of people that I know use it. We tend to give it actually at MGH, we give it for a lot of people who have trouble sleeping in the hospital, because in the hospital it's really hard to sleep because there's so much stuff going on. And most of the patients say, I mean, you don't have a lot of side effects, and so it's just really nice, easy way to get to sleep without feeling like you're, taking something that's going to cause you to feel all messed up the next day. Yeah.
But I know that sometimes switch it to a Ramelteon. Is there a reason why?
I've never heard that, so that's really interesting, and I'm going to look that up now. Yeah, I don't know about melatonin being more likely to cause delirium than Ramelteon. I mean, that's what I would guess. Yeah, I would be more inclined to assume that that's what's going on. So when people have delirium, though, have you guys learned? No, you learned delirium later in this semester, I think. But so delirium is this case of like people being out of touch with reality, but also like in a completely just altered mental state. And so any sedating agents can cause and worsen delirium. So when people are delirious, then we will start to remove lots of sedating agents from them because it tends to help them clear up and get in a better state. But that being said, I don't really know why I wouldn't expect there to be a significant difference between melatonin and Ramelteon. Good question. So dosing is somewhere between 0.5 milligram and 10 milligrams, 30 minutes before bedtime. Nothing crazy. So and that's for melatonin. So for Ramelteon, like I said, this is this FDA-approved agent. So that dose is 8 milligrams within 30 minutes of bedtime. So, and again, not after a high-fat meal because that'll slow absorption. So this is another one of those, both melatonin and Ramelteon, you kind of want to be like, I'm ready to go to bed now, I'm going to take this pill, I'm going to lay in bed, and that's going to help me fall asleep within the next 30 minutes. These are things that they will make you sleepy, and so you don't want to be like doing things or needing to be awake and taking these medications. For both of these agents, it could take a while in order to start getting a positive or like a helpful benefit with your sleep, but that's what the data says, but I can tell you from people that I know's experience with specifically melatonin, it usually works pretty much right away. Is that what you guys would say? It work right away? Plus, minus? Okay. You shouldn't see dependence develop with these agents. You could see, especially at the higher doses, some next day drowsiness, maybe some GI upset. Women could have increased prolactin and men could have decreased testosterone. That's what the study showed with Ramelteon, but I haven't heard much about any of those kinds of side effects with melatonin. But I would kind of expect that they would be fairly similar because the agents are so similar to each other. So for Ramelteon, 1A2, so CYP1A2 and 3A4 inhibitors or inducers will adjust the levels of it, and contraindication would be a strong CYP1A2 inhibitor because that would raise levels of Ramelteon too high. So question 12. Polly is a 32-year-old female who works in sales and travels frequently. She presents to the pharmacy and asks if there is any medication that can help with adjusting to time changes when she travels. Which of the following recommendations would you make? Ask PCP for a prescription for Zalopon. Ask the PCP for a prescription for Trazodone. Meds aren't needed. Try sleep hygiene techniques. Or try melatonin 3 milligrams at night as needed for jet lag. Okay. What's the thing? Yeah, that one was pretty obvious. So the melatonin receptor agonists are really helpful, especially for jet lag. Oops, I didn't have an arrow on that one. So the answer there is D. Okay, over-the-counter agents. So a lot of people have experience with over-the-counter agents. I've never taken specifically like diphenhydramine in order to fall asleep, but I've definitely taken NyQuil when I've had a cold, and I know it's going to help me sleep throughout the night. So all of the over-the-counter agents either contain diphenhydramine or doxylamine. Those are the only two over-the-counter sleep aid medications. So even though they may have a bunch of different names, and you can go to the aisle and it says sleep aids and there's like 45 different types of medications, the thing that's making people sleep inside of those medications is either diphenhydramine or doxylamine, or maybe melatonin if they keep it in that section. So their mechanism of action is also antihistaminergic, so kind of in the same way that the sedating antidepressants work. They just have no antidepressant effects whatsoever. So you could consider using them for transient insomnia. So if people have like a little bit of, they're having trouble sleeping for a period of time that they expect to be quite short, you could try recommending something like one of these agents. But they really shouldn't be used after 10 days. At about the 10-day mark is when people say their tolerance like really develops, and to the point where most people say it doesn't work at all after about 10 days. These agents are definitely likely to cause next day drowsiness. Has anybody ever taken one of these and felt like woozy the next day? I definitely. Like, I can't even function after I take NyQuil. I have to take the next day off work if I take NyQuil one night because I'm like, it's like I'm drunk. Like, I'm not functioning at all. I'm like slurring my words half the time. I can't keep my eyes open. It like really, really affects me. But I know like some other people, like they don't have that effect whatsoever. So everybody's different. So as far as dosing goes, diphenhydramine is 50 milligrams at bedtime, and doxylamine is 25 milligrams at bedtime. So adverse effects, as you would expect, would be anticholinergic. So these are the same things like we saw with the other agents. So blurred vision, dry mouth, constipation, flushing. So technically, we could consider alcohol to be an over-the-counter agent. It makes people sleepy. And it does kind of cause that like initial sedation. But what really happens with alcohol is that while it's easier maybe to fall asleep, it really disrupts, kind of like benzos, it definitely disrupts restorative sleep. So you get no restorative sleep with alcohol whatsoever. And then it also makes it easier for you to wake up throughout the middle of the night. So if anybody's ever had like a really intense night of drinking, which I know none of you have had that in college, right? You may have experienced some of this, like where you kind of like wake up at like 2 in the morning and you can't fall back asleep and you're just laying there. And you're just like, oh my God, I'm so uncomfortable because I'm starting to get hungover and I can't fall back asleep. That happens, and that's really common with alcohol. And then maybe you will fall back asleep and then you'll wake up at like 6 in the morning. And you're like, shoot, I really wanted to wake up at like 11 because today sucks and this feels awful. So it's very common with alcohol, and so what you'll see is like you'll see a lot of people who will say like, oh, I have 2 fingers of whiskey before I go to bed, or I have a glass of wine with dinner, and that helps me like settle down for the day and be ready for bed at night. But even as little as 1 drink per night can actually affect that whole sleep architecture and can reduce the amount of restorative sleep that we get. So it's pretty interesting. And then the other thing, so I have here, may cause snoring and apneas. So what happens is because alcohol also reduces our respiratory drive, kind of like benzos and a whole bunch of other agents. So it reduces our respiratory drive, and it can cause that kind of collapse of the breathing passages. And so when we're laying in bed at night, it can be more like it's easier for our bodies to start snoring and have those apneas where it's like actual periods of time throughout the night that we don't have any oxygen coming in at all because our breathing passages have closed. And so that causes us to wake up. And that's very oftentimes or sometimes what causes you to wake up when you wake up in the middle of the night because of alcohol. And because you're not getting that deep restorative sleep, you're not getting deep enough to just kind of sleep through it. So yeah, I thought that meme was funny. 7 beers. So, I'm really ahead of time, so sorry about that. But next question. So I want you guys to kind of just yell out the answers. What kinds of patients or situations might be best for recommending over-the-counter sleep aids? So first we'll talk about which ones are best for over-the-counter sleep aids. So melatonin, let's start with melatonin. Jet lag. Anything else for melatonin? I heard something. Yeah. So a change in your like work shift, definitely. How about diphenhydramine or doxylamine? I consider those to be the same thing. So somebody who needs it for a short period of time. Yeah. I think I did this. So yeah, needs it for a short period of time. People who can tolerate the next day drowsiness, that's definitely something to think about. And so maybe even saying to them, okay, take this, but make sure that like you don't have to do anything the next day because we don't know how you're going to react to it, and we want to make sure that if you do need to just sleep until 1 p.m. the next day, that's okay. What's that? Yeah, so you could like combine it with like one of the other kinds of like cough, cold, and flu agents, definitely. I think I had another idea, but oh, okay. So who do you want to avoid them in? Can you elaborate on that a little bit? Definitely. So like if somebody comes in, and once we get to the bipolar lecture, you'll start to have a good understanding of what mania looks like. But like somebody comes in and they're talking 100 miles an hour, and you can't even interrupt them, and they're like, I need to sleep, I gotta get something to sleep. And they are like, their hair's a mess, and like everything looks like kind of really intense, and like too much is going on for this person. Maybe they're in like a manic state. And yes, they do need to get to sleep, but Benadryl is not going to help them fall asleep. They need to be admitted to the hospital and get lots of benzos. So sure, of course, if there's something else that's causing the insomnia, you definitely want to be able to address that other thing and not just be kind of like trying to cover it up with a very tiny little Band-Aid. Who else would you want to avoid them in? What was that? The elderly. Yeah, right? Like a lot of them are on the Beers list. And so a lot of agents that are quite sedating are also on the Beers list for people. Let's see what else I have. So also people who have more of like chronic insomnia problems. So what's good for those people? Primary chronic insomnia for like months and months. You're going to just tell them like, go take some Benadryl and be fine? So maybe another agent that's got a little bit more evidence behind it. What else? One of the Z drugs? Okay. What else? CBT. They need to change the way they think about their sleep. They need to reduce their anxiety that they have when they experience sleep or when they're trying to sleep. So definitely you want to get them into therapy. You can sort of start a medication maybe, but actually I know a lot of therapists that won't take patients for CBT for insomnia who are on medication, because so much of the CBT for insomnia is about really getting used to like yourself without this kind of confounding factor of a medication, and reducing the anxiety that you're experiencing without some sort of like medical or medication kind of numbing out a lot of that anxiety. And then also patients with a history of substance use. So like what we were talking about with if they're sick and you want to give them like NyQuil or some other kind of like cough syrup or something that also has diphenhydramine or doxylamine in it. Well, those syrups also usually are like, what, 11% alcohol? So if it's somebody with an alcohol use disorder or some other type of substance use disorder, you don't want to give them something that has alcohol in it. I know, we had this one patient, and like we don't really believe this patient, but she was admitted to the hospital for like pancreatitis, and it was related to alcohol. And so, but she's like, no, I had alcohol use disorder. I've been in remission for like, I don't know, some amount of years. And she's like, I think that it's cough syrup. And we're like, okay, like the 2 tablespoons that you take of cough syrup maybe 4 times a day is like not going to cause pancreatitis. So we were kind of thinking that she was like robo-tripping most of the time. But you can definitely get people who are drinking bottles and bottles and bottles of cough syrup. So you want to be really careful when you're making those recommendations. And like, really, what's the best way to get to know all of this stuff? Somebody just comes in and says, what medication can you recommend for my sleep? What do you do? Get the history. You want to ask them the questions. Tell me about your sleep. How have things been going for you? How long has this been happening? What else do you have going on? And it might be kind of uncomfortable to do that in the aisle way of a pharmacy, but maybe your pharmacy has like a little counseling area and you can talk about it there. Or maybe this is somebody who is like, maybe you're an ambulatory care pharmacist and they're coming to you for diabetes management and they tell you that they're having trouble sleeping. What can you do for them? And you can also do these interventions at that time. Okay. Mr. Stark is a 23-year-old male with history of anxiety and insomnia. He has responded well to clonazepam 1 milligram twice a day for both his anxiety and his insomnia for the past 2 years. He presents to his PCP today and states his insomnia has been worsening over the past 2 to 3 months. What would you recommend to his PCP? Would you stop clonazepam because it's not supposed to be used beyond 10 days? Would you slowly taper off clonazepam over 1 to 2 months because it's not supposed to be used beyond 10 days? Would you increase clonazepam to 1 milligram every morning and 2 milligrams at night because that should improve his insomnia symptoms? Or would you increase clonazepam to 2 milligrams twice a day to address both the anxiety and the insomnia symptoms? Okay. Okay. So for people who, I'm just going to go through this because I'm going to try to take up time. Okay. So for people who chose D, can you tell me why? Anybody willing? Go for it. Okay, so you were saying it. Okay. So, right. And what's the biggest risk with benzo withdrawal? Seizure that can cause death. Yes. So, yep. So that's definitely valid. So for the people who thought, well, what if we did 1 milligram in the morning and 2 milligrams at night, because then that's going to help them sleep. Who? Tell me about the thinking behind that. Go for it.
Well, I guess I was thinking
Okay. Any other thoughts? Any thoughts about that? So the idea is, well, the agent is helping with this person's anxiety. And so we don't want to take that off because it's helping the anxiety. Maybe we can increase it a little bit at night to just help with the insomnia. Any kind of we can start a little debate. Anybody who doesn't think that's a good idea?
it might not be the best for insomnia because it's not
Right, because what's it doing with that sleep architecture? What does it do? It reduces the restorative sleep, and then we just get the increase in stage 2. So, so one thing that I guess I shouldn't expect you guys to know yet, because I haven't taught you anxiety yet, but is that benzos are actually not very good for anxiety. And so even though this PCP thinks he's doing good by Mr. Stark and saying, I'm treating your anxiety, I'm giving you this clonazepam, it's actually a really not good treatment choice at all. And we'll talk a lot about that when we get into the anxiety lecture. But the fact is that Mr. Stark, as a young guy who's now, what's this called? So it was working for 2 years, 1 milligram twice a day. Now for the last 2 to 3 months, it's not working. What's that called? Tolerance, exactly. So he's starting to develop tolerance. And while tolerance does not mean addiction, it really doesn't, it's a criteria on the big list of diagnostic criteria for addiction. And we'll talk about that when we get to that lecture. But so when somebody starts developing tolerance, then we do start getting worried that maybe we're going down that pathway, and we really don't want to go down that pathway, especially in somebody so young. So really the most appropriate option here would be to slowly taper off over a period of 1 to 2 months, because 2 milligrams a day of clonazepam it's not a high dose, but it's a decent dose. And if you stopped it suddenly, you could definitely have lots of withdrawal symptoms. And they're really not intended, either in anxiety or insomnia, intended to be used for longer than 10 days. Yeah, any questions about that? Does that make sense? Okay. Okay, I think this is my last slide. So, we just talked about this. Shoot. Oh, well. So we built up a tolerance. It's probably not making his anxiety and sleep worse. It's probably making his anxiety and sleep worse overall, because you can get that rebound insomnia, especially when you come off of it. You can also get rebound anxiety. You want to minimize the withdrawal and seizure risk. So you want to come off over a long period of time. And because he's not doing any, so like if he was going through his prescriptions really like quickly, like it was a 30-day prescription and he went through it in 10 days, or it's, you're concerned that he's selling it or something like that, then we definitely would cut him off pretty quickly and do like a 5-day, 3-day taper, something very quick. But if this is somebody who gets his medication on time every single month and he's not taking any extras and it doesn't look like what we call aberrant drug-related behaviors, he's not doing any of that, then we're not worried, and we'll just do a lot of education and say this looks like it's not working for you anymore. We can try a bunch of other agents that are going to help with both sleep and anxiety that are better for sleep and anxiety, and get you off of this in general so you don't feel like you need this medication anymore. And then we talked about the rebound. So that's the lecture. What questions do you guys have? I can't promise that all my lectures will end early. Will there be a period of will there be a point where we restart clonazepam? Does anybody else have any thoughts on that? Would you restart clonazepam? So say he goes off of it for like a year, and he gets on something else, and it's going fine, but then some other symptoms come back up. Would you consider restarting clonazepam? Some people are saying, a lot of people are saying yes. Does anybody say no? Why? Okay. So for the people who said yes, why do you say yes? What's that? The receptors would upregulate after they went off of it. So probably. That would probably happen. My thought is we know what happened with the clonazepam the first time. Took him 2 years to get tolerant, and then he got tolerant, and then now he needed to come off of it. So why do we think that it would be different this second time? That's kind of my thought. So I definitely would not restart him on clonazepam. Also, and I should preface this by saying I'm like anti-benzo in like every way that you could imagine being anti-benzo. So I'm very biased in this, and you'll see that comes across in a lot of the stuff that we do throughout the lectures. So the trend nowadays is to really start getting people off of benzos because it turns out they're not that great. They have a few very necessary indications: seizures and mania and catatonia, and that's about it. And after that, people don't really need benzos. Even though people may have panic attacks or people may have really difficult time sleeping or they have really debilitating anxiety, we found that there's better ways to treat these things rather than just giving them a benzo. And the reason for that is I have a coworker who's in recovery, and she says, I was addicted to alcohol. She was addicted to alcohol and opiates and all these things. And she says, well, my addiction to alcohol was really benzos. And she says, I chewed my booze. She always says that, I chewed my booze. Because they do the exact same thing. Benzos and alcohol are attaching to the exact same spot, that nonspecific attachment to the alpha subunits of the GABA A receptor. So you're effectively just taking a pill that's doing the same thing that a shot of whiskey is going to do for you. So that's probably, if we can all kind of think about it that way, we can kind of start to think like, okay, that's probably not good for anybody, right? Okay, so I'll let you guys go. Thanks.